Currently,
between
there are
52.
Currently 52. So I would like to know from them if they can interact with me directly or they can put their answers in the chat box. How many of them have witnessed an autopsy, medical autopsy? Now, what in next 1 hour would be useful to you or not useful to you, or you're just feeling like sitting at the back bench or maybe putting it online, log in and then play back. So maybe half of you probably would be feeling like this. Am I right? And maybe some of you would be feeling like this. Do you remember this picture?
Yes.
Yeah. So are you feeling like idiots in this cardiac pathology class discussion?
But there's a query that there's someone who's told that feel interested but don't see the scope in private sector.
Right. Yeah. I totally agree with that. But then, if you're really interested to do so, you can join one of the institutes for a week, 10 days, or maybe 2 weeks to see how the medical autopsies are done as an observer. Right. So that option is always open both at PGI and some other hospitals where autopsies are being done. One of them is KA Mumbai, those who belong to that part of the country. Okay. Now let's go. So the first thing when you do a medical autopsy, since this talk is going to be focused on the cardiac dissection, right? So I'm going to talk about only the cardiac dissection in autopsy and the explant hearts, and it's going to be a case-based discussion. So before we go on to the proper case-based discussion, let's talk about the relationship of the heart in the body. So when we say that, so we mean that you all probably would be knowing by now situs solitus and situs inversus. So solitus means that the organs in the body are in their normal position, and the normal position is that the heart is pointing towards the left, the stomach on the left, the spleen on the left, and on the right side you have the liver, right? So that is what is called as situs solitus. When we say situs inversus, that means everything is reversed. But what is constant is this auricles. The auricles never move their positions, whether they are the right side or on the left side. So they remain constant, and by that you can make out whether there is situs solitus or situs inversus, right? So you should remember that we are looking at the 3D structures in the body, but when we examine it, it becomes just unidimensional. Okay. So now, once we are talking about the auricle, so this is the right auricle, which is very broad, having kind of a triangular shape and no or minimal crenellations. By crenellation means this indentation. Whereas if you compare the left side auricle, which is smaller and it's got something like lace-like pattern, this is called as crenellations. So that's how you identify the right and left atrial appendage. And once you identify that, you know that the appendage on the right side will be linked to the opening into the right atrium, whereas on the left side will be opening into the left atrium. So this is the most important aspect of identifying a heart, especially when there is dextrocardia or there is levocardia. So dextrocardia, we know that the heart is going to be rotated on the right side, whereas the apex would point towards the right side. And levocardia, it's in the normal position, that is the situs solitus position. Okay. Now the other important thing when you do the cardiac dissection is knowing about these sinuses. So one is called the oblique sinus, that is this one, and the oblique sinus lies between the two pulmonary veins and in the inferior vena. So as highlighted by this arrow, and the transverse sinus is between the auricles, the atrium, the pulmonary vein, and the major arteries, which is the pulmonary trunk and the aorta. So the importance lies is when there is a dissection of the sinus of valsalva. So that there becomes a site of accumulation of the blood, and there's an hematoma formation in the transverse sinus. So that's the importance of knowing the sinuses. And especially when you're opening the aorta or the pulmonary trunk, you have to open up these sinuses before that. So these are the pericardial reflections over the heart. Now, let's see how do we approach the dissection of the heart. The first thing which you notice, most of the times the autopsy form does not state whether the patient died in systole, diastole, or asystole. That's very important because if the patient has died in systole, the heart would be very firm in consistency. And I'll come to that why it is important to know that. If it is in diastole, the heart will be relaxed. And if it is asystole, it will be moderate to firm consistency, right? So it's important to know ideally, but most of the times we do not know in which state the patient has died, right? Immediately after that, the heart is usually flaccid, that is soft to feel. And after 1 hour, the rigor mortis sets in, which resembles the systole, and that makes the heart muscle feel firm. And if the autopsy is not performed within 24 hours, the chambers again become dilated, and that can resemble dilated cardiomyopathy. So you need to be aware of these points, that what causes what. And also when you fix the heart with 10% perfect formalin, the myocardial thickness increases by nearly 10%, right? So the weight of the heart is to be taken at the time of autopsy, that is the accurate weight or exact weight. Otherwise, it will give you false reading by plus and minus 10%. And of course, we usually at PG do either by putting the heart in the heart bucket, which is full of formalin. So the percentage of the organ to the formalin should be 1 in 10, or you can do perfusion fixator. So how do you remove the heart? So first of all, of course, you remove the chest plate, right, by chisel, hammer, and the bone saw. You do the in situ examination, identify whether there is situs solitus or situs inversus, whether there is dextrocardia or there is levocardia, right? Then you examine the pericardium for its adhesion, any effusion, and any history of open heart surgeries. Now, mind you, even if you do not know that the patient has underwent an open heart surgery, if there is absent right auricle, you know that patient has undergone right open heart surgery. Most of the time, the root of surgery is through the right auricle, so that will be missing. Then, of course, you look for pericarditis, you look for any gross anomaly vis-a-vis related to congenital cardiac diseases. Now, one clue which comes by gross examination is multiple spleniculi, multiple spleens. So if they are present, usually they have an association with congenital cardiac disease. And then, of course, if there is any aortic dissection, and that you have to see, as I just told you, the accumulation of the blood within the transverse sinus. Along with that, then you remove the heart and lung complex in toto. And you remove the vessels by cutting them as long as possible. So you include part of the ascending aorta, the arch of the aorta, and part of descending aorta as well. And then it should be fixed in the distended state. Now, sometimes my residents ask me that we find it difficult to open up the heart. Yeah, cardiac dissection is a little bit tricky, but once you know how to follow the flow of the blood, it becomes a little easy. And for fixation, you put the cotton soaked in formalin into the chambers after opening up the chambers and put it in the heart bucket, or you do a perfusion fixation. Now, this is how the perfusion fixation works. So you just clamp the major arteries, you connect the tube with the aorta, and clamp all the outlets, right? And by the flow of the gravity, this formalin will go into the right side of the left side of the heart. Now, this will only fix the left side of the heart. So it is good to fix the heart in this situation, especially in cases of ischemic heart disease, because all the coronaries will get nicely fixed, and when you dissect them, they'll be nice, round in shape rather than flat and irregular in shape. Okay, this photograph I borrowed from Dr. Pradeep, thanks to him. Now, what is the most important thing after you have dissected the heart? So that's the heart weight, which is the most reliable single measurement at autopsy for correlation with any cardiac disease states. So can anybody tell me what is the percentage of the heart weight against the body weight? Anybody has any answer? Anybody? Rough guesses. What percentage of the heart would be as compared to the body weight? So if the body weight is 70 kgs, how much would be the heart weight? Any answers? Have I got?
No answers.
Not yet. So I'll tell you later. So as I told you that the great vessels to be trimmed 2 centimeters in length, and you have to remove all the clots. Otherwise, they'll cause discoloration of the endocardium. And you record the weight plus and minus 5 grams in the adults and plus and minus 0.1 gram in the infants. And as I told you, fixation alters the weight by 5 to 10%. So normally the heart weight compared to the body weight is just only 0.1 to 0.3%. As you know, most of our body weight is by fluids and bones. That is nearly 70%. It's only 30% of the body weight is with the solid organs. And amongst the solid organs, liver is the biggest, followed by kidneys, and then comes the heart. Lung is all air, the brain is above, and that usually weighs 1000 grams. So the cardiac weight amounts to only 0.1 to 0.3% of the body weight. Remember that in general. Now, what are the cardiac dissection methods? So I would be dealing with only the first four, because the later four deals with either with the museum specimens or for the fixation and mounting of specimens, and they cause quite mutilation of the heart specimens. So we usually do not follow these dissection methods. We usually follow inflow-outflow method, short axis method, 4-chamber, or the long axis method. And I always tell my residents to focus on the first three, because even the long axis method is not very well connected. It causes distortion, and it does not give you the foolproof picture of the cardiac chambers, right? Okay. So now first thing you notice after removal of the heart, what is the color of the myocardium? Is it pale grey in color, which is seen in the old infarction, or maybe the entire heart is pale, which is seen in anemic disorders, or it is having a mottled or hemorrhagic spots, which can be seen in acute infarction, which may or may not cause a rupture. What is the shape? So normally the apex of the heart is conical in shape and is pointing towards the left. So that's a normal shape. But if it becomes globoid, irregular, it could be either because of the cardiomyopathy, thromboembolism, or maybe there's a space occupying lesion, or there could be ventricular aneurysm for any further cause. And if there is one or more chamber dilatation, which is containing neural thrombus, it's usually seen in cases of dilated cardiomyopathy. And always examine both the auricles, that is right and left, for any presence of neural thrombus. And neural thrombus you identify by the color of the auricles, that is, they will be discolored and they'll be very firm to feel. And after doing that, you have to measure the wall thickness, the valve size, and of course you have to measure the pericardial fluid. Now, I will not go into the detail of it, because unless until you do it, probably you will not be able to remember it also. So let's go to the next point, that is how to measure the wall thickness and how to assess whether it is just hypertrophic or it is just contraction due to the systole. So left ventricular hypertrophy, when we talk of, it is usually firm, and there could be increase in the wall thickness by the fibrosis, amyloidosis, calcification, or even in the rigor mortis. And when it is soft in consistency, it is secondary to the infarction, myocarditis, or in early stages of dilated cardiomyopathy, and of course decomposition. We usually do not encounter decomposed bodies. That is usually dealt by the forensic people, right? Okay. Now, if you see these two hearts, now there is one heart which is in the fresh state, and this on the left side of my left side is on the fixed state. So what you see is a very irregular shaggy surface on the left side. So that means that this patient had, and if you see there is a dehiscence of the myocardium in the lower half, and there are a lot of clots. So that means that this patient has undergone myocardial infarction, acute myocardial infarction with aneurysmal dilatation, which has undergone rupture. And on the right side, you can see a pericardial sac with some blood here and there, fresh blood at the time of dissection. So this is what the normal myocardium looks like on gross inspection, and this is after the fixation, right? Now let me take you to the journey of cardiac dissection. So how do you open? Usually we follow the inflow-outflow tract method, right? Which is the most easiest to follow and most easiest to reconstruct. So you know that there is IVC and there is SVC. So starting from the IVC till the root of the right auricle, you make a clean cut to open the right atrium and right auricle. Now see, this is the right auricle, which is again triangular and broad. It is not discolored, and of course I cannot tell you the consistency right now, but if you feel it, it will be soft in consistency. So there is no presence of thrombus. So why you choose IVC? Because if you choose SVC, most of the time the SA node lies at the root of SVC. So we don't want to damage the SA node. That's why we choose IVC and connect these two to open up the right atrium. And this is the opened up right atrium. Now how do you identify right atrium? You see these linear muscles. These are called as musculae pectinate. So this is the rough part of the right atrium, and then there is a smooth part also. Of course, when you have a rough part, you have a smooth part also. As in life also, you have rough patches and you have smooth patches. This is separated by crista terminalis or supraventricularis, also called as. So this is the smooth part of the right atrium, and this is the rough part, and this is how you identify the right auricle. Now there lies the SA node. This is the fossa ovalis, and there lies the triangle of Hope, where lies the AV node. We'll come to that later, a little bit later. Now, once the right atrium is, and this is your tricuspid valve. You see, this is the septal leaflet, the posterior leaflet, and the anterior leaflet. So three cusps seen right here, and these fine structures are the choric entity, and they are attached to the papillary muscles. Okay, and this is your coronary sinus, which is being pointed by the arrow. Now, next thing is you want to open up the pulmonary artery. So you turn the heart anteriorly, and we know that the pulmonary artery lies anterior to the aorta. This is the aorta, right? So you pass a forceps from the right ventricle to the pulmonary artery, and use the larger, bigger knife to open up the right ventricle. And as you reach the pulmonary artery, open up the pulmonary artery by scissors. Why using scissors? Because pulmonary artery is an elastic artery, so you'll not be able to cut with the knife. So you have to use the scissors, right? And this is the inflow incision of the posterior wall parallel to the septum of the heart. Now we've opened up the right side. Now let's come to the left side. Left side is relatively easy because you just have to join the pulmonary arteries. You know that pulmonary arteries there, you just join them in the crisscross manner. So you open up the left atrium. You see, this is the right atrium already opened up, and this is the left atrium, and this is opened up left atrium. This is the foramen ovale, which is seen from the left side. You have the coronary sinus. This is anterior mitral leaflet, which is much more taller. This is how I always tell my residents that how to differentiate posterior mitral leaflet from anterior. So posterior occupies much more area, that is wider, and anterior is much more taller. And it is the anterior mitral leaflet which separates the inflow of the left side from the outflow. Okay, so by thereby means if there is anything happening in the anterior mitral leaflet, it may cause obstruction to the outflow of the left side. Now once we have opened, and if you see the endocardium here, let's go back to the previous. The endocardium on the right side is little thin, translucent, whereas the endocardium on the left side is little opaque, because the jet of the blood and the pressure of blood is more on the left side. And compare the papillary muscles here, they're much more thicker here compared to the right side. So the trabeculations are much coarser on the right side compared to the left side. Now we come on to the left outflow tract, that is opening of aorta. Now you identify the aorta, largest elastic artery, and anterior to that lies the pulmonary artery. We already opened up the pulmonary artery to open up the right ventricle. We pass on a forceps again from the left ventricle to the aorta and open up the left side of the heart, that is the outflow tract. And this is the open of aorta, right? And you can see some atherosclerotic plaques here, and these are semilunar valves seen of the aortic valve. So three cusps are there. This is your coronary sinus. This is the right coronary sinus. Left coronary sinus is usually cut, and this is the non-coronary sinus. And the importance of non-coronary sinus is in rupture of sinus of Valsalva. And as I was trying to tell you, that this rupture causes bleeding into the transverse sinus. The first slide which I showed you. So that's the importance of this transverse sinus when there is rupture of sinus of Valsalva. Now these are the pictures which shows you the left atrium, inflow tract, and the left ventricle again, the outflow tract, and this is the right ventricle because it's thin. You see the muscle thickness? That's how you differentiate. So the ventricular thickness of the right side is measured around 1 centimeter below the pulmonary valve, and this is the cross section, the apical cut of the heart. So if in a suspected case of myocarditis, this is how we take the sections. So one section and make it like a plus. This is the right side ventricular cavity which is dilated, and it is a crescent shaped cavity, whereas the left side cavity is more rounded. Okay. Now the next dissection method is short axis. The other name for this is also called as short axis method. So you start from the apex of the heart till the base of the heart. So base of the heart, there are two bases of the heart. One is anatomical base and the second one is surgical base. So we are talking about the surgical base, which is the ventriculo-aortic groove, right? So till that, we keep on dissecting it till we reach that groove. Anatomical base is where the heart is resting in the body. And this is how it looks like on the cross section. Now some of you might be thinking that there is a kind of blackish discoloration in the subendocardium. Now this is the endocardium and this is the myocardium. Now this portion of the myocardium is compact because it is thick muscle, and wherever you see the trabeculation, this is called as non-compacted myocardium. This is discolored. This happens when you leave the blood clots in the cardiac chambers, right? Whereas compared to this one, there is a difference in these pictures. If you see, there is a hemorrhagic or congested areas in the subendocardial region, and in this area it is almost transmural, so involving the entire thickness of the wall of the ventricle. So this is a case of myocardial infarction, very fresh myocardial infarction compared to this. This is just the postmortem staining. Okay. Now let's see how the normal myocardial cavity, the ventricular cavity looks like. This is normal. So the very rough way to examine the ventricular cavity is just to insinuate your little finger at the base of the papillary muscle. If you're able to do so, it's normal. But it's a very crude method, and everybody's finger size is different. But that's a general connotation, especially for Indian patients. So it's round in contour, whereas the right ventricle is crescent in shape. Now this is what the left ventricular hypertrophy looks like. Now you see the difference in the size of the chambers of the left ventricle. This is much more narrow, and there are some whitish areas, right? I'll come to that later. Why there are whitish areas here. And this is grossly dilated both the ventricular chambers. So this is left ventricular hypertrophy, which is concentric in nature, and this is dilatation of both the chambers, which happens in dilated cardiomyopathy. And you can also see some mural thrombus present in the ventricular chambers. And this is how what the hypertrophic cardiomyopathy looks like. So you have a septal hypertrophy, and the thickness of the septum should be that unlucky 13. So unlucky 13 crosses it millimeters, not centimeters, right? It is significant for diagnosing HCM, right? And you see, these are again the coronal slices of one of the cases at our lab in our autopsy collection. You see concentric left ventricular hypertrophy, and there are these pale whitish areas in between. The first thing I told you was look at the color of the myocardium. So this one has pale areas, this one also has pale areas in between, and this one has a little dark color. You know, this also you have these pale areas, and the ventricle wall is thinned out focally. Compare this area versus this area. So there is thinning of the wall, and you can see that this is thinned out. So this is secondary to the chronic or late healed myocardial infarction. Now let's come to the next method, that is a four-chamber method. Four-chamber method is usually followed for either dilated cardiomyopathy or hypertrophic cardiomyopathy. Why so? Because you want to see the septal thickness, which is usually irregular in hypertrophic cardiomyopathy. Normally the septum is inverted S, right? This is your ventricular septum. This is your right side, this is your left side, right ventricular and left ventricle. If you see the chamber cavity, there is marked reduction in the chamber cavity of the left side, and there is irregular septal hypertrophy. It's much more prominent on the near the AV groove rather than at the apex. So this is a classical case of hypertrophic cardiomyopathy, where this is a case of dilated cardiomyopathy, where you see dilatation of the ventricular chambers of both sides. So you compare this, the septum thickness here and the wall thickness here, more or less same, right? But there is marked dilatation of the ventricular cavity with little pale white grayish areas, which indicates endocardial sclerosis secondary to the disease process. And then there lies a pacemaker lead, right? You see here, the pacemaker lead usually follows from the right auricle. Now see, part of the right auricle is absent here. So this patient had pacemaker in situ, and it goes to the septum of the heart because the pulse has to come from up and gets transmitted to bundle of his and to the free wall of the right ventricle. Okay, and this is one of our cases. This was a case of again hypertrophic cardiomyopathy. You see the thickness of the septum, right? Now since this heart was opened up with the inflow-outflow tract earlier, the resident was not aware about the diagnosis, so he opened it, and I did later on the four-chamber method. So the right atrium again here, right auricle, right atrium, left side, and left ventricle. You see the complete narrowing of the left ventricular cavity and replacement fibrosis as seen as pale gray areas. Okay. So we now go. Yeah, sure. Yeah.
First question is, do you collect heart blood during the autopsy for blood culture and the procedure?
Okay, so we usually collect the blood sample from the left side of the heart, but that is only possible if you're doing the autopsy in less than 1 to 2 hours. After that, it becomes a clot, and it will be difficult to for the prosector to collect the blood. So you use a thick needle that is around 21 G or maybe thicker than that, and a 20 ml syringe. You hold the heart in situ before you cut the great arteries, and you hold the heart, and from the apex you go into the left ventricular chamber, and you pull out with the negative suction, you just pull out collect this blood sample from the left side of the heart. And then for whatever reasons you want to preserve it, either you put it in the culture bottles or you want to preserve it at -80 or -20, you preserve it for future use, right?
Yes. That's the way. Second question is, do you do a coronary artery dissection before?
Yes, I'll come to that. Slowly I'll come to that. Okay.
That's not for now.
Yeah. So now one more important thing I want to highlight here is that physiological hypertrophy. Some people who are athletes, they will have increased muscle mass. So you are not going to call it as ventricular hypertrophy because, especially in athletic patients. Then of course decomposition versus dilatation. So as I told you earlier also, when there is decomposition, the chambers become dilated. So you need to differentiate between the two. And of course, I told you doing the postmortem, if it's happening in less than 24 hours and either mode passes, there will be natural dilatation of the chamber, and then that will create problem in diagnosis of dilated cardiomyopathy, right? And of course, in our country, we still have cases of rheumatic heart disease, so you need to examine the cardiac valves. And they need to be examined from an aerial view before you cut open the heart. So you need to see the narrowing and patency of the valve. There is a calibrated device. You put that calibrated device into the lumen of the valve, and you see how much the diameter of the valve is for any calcification, for any commissural fusion, or any vegetation. These are the three important things which you examine before opening of the valves. And of course, you write down, especially in rheumatic heart disease, you mention whether it is fish mouth or it is buttonhole type of occlusion of the or narrowing of the valve. Now, this is for the person who asked about the coronary dissection. Now you see, coronary, this is left anterior descending, left circumflex, and right coronary artery. So if you do a perfusion techniques, your coronary arteries will be nice and round. But here they are little oblique and oblong. So this will not happen if you do a perfusion technique fixation. So they need to be examined for any calcification, tortuosity, or any atherosclerotic marks. And each 5 millimeters, 3.5 to 5 millimeters, you do the coronary artery dissection, and you do it with a scalpel. And you hold the scalpel like you hold a pen, and you keep on dissecting the coronary arteries till such time you don't see a lumen. Okay.
Madam, there's one more question.
Yeah,
For hypertrophy,
I can't hear you now.
Madam, for hypertrophy, how much is the cutoff value of thickness? And
I'll come to that. When I come to the case-based discussion, I'll talk about it. Yeah.
Thank you.
So now there are certain specific conditions like rheumatic heart disease, coronary artery bypass graft, or there is LVD, that is LVAD. It's called as left ventricular assist device. Sorry about the typing error. It is LVAD. Or there is pacemakers. So in RSD, I just told you that you have to examine the mitral valve deflect, tricuspid valve deflect for any narrowing, for any vegetation and commissural fusion. Also, you need to examine the aortic valve, right? And of course, for any prosthetic valves, what type of the valve it is, the suture is intact or not, is there any ulceration, is there any thrombosis, or any dehiscence of the wound. In CABG patients, you look about the type of the graft, whether it is arterial or it is venous. In addition to that, which type of, so usually when you open up a CABG heart, you find a loop of the artery. Usually the first artery to be grafted is left internal memory artery. And they just pull out the left internal memory artery and make a loop and connect it to the left anterior descent artery, right? So you have to look out that before you dissect the heart, okay? LVAD usually causes continuous trauma to the endocardium and lead on to thrombosis in the ventricles. And of course, any pacemaker can lead on to thrombosis, infection, or even breakage, which can result in arrhythmia or even maybe sudden death. And for CABG, I told you that open heart surgeries will not have proper right auricle. It will be half chopped off. Evidence of pericarditis will be there, so that's a history that the patient has undergone prior surgery. Of course, number and location of bypass arteries to be looked for, and of course, from where the loop has been made. And you have to examine the graft arteries first before sectioning any native arteries, because once you cut it, you will not know from where the graft was made. And of course, then you examine it for any graft vessel atherosclerosis, narrowing, or any other problem in the suture site. And usually the cardiac surgeons use a blue-colored suture. It's a silk suture, right? So you can easily visualize that. And of course, later on you examine the coronaries, whether they are the degree of involvement of the coronaries by atherosclerotic causes. Now let's come to the explant heart. Now explant heart, I guess most of the people are versed with the term. That is the heart which is removed from a patient who is undergoing cardiac transplantation. So that also comes to the pathology department. And the first hour is the golden period. Why so? Because most of the times the transplantation is done in end-stage cardiac failure patients, and usually these patients are of dilated cardiomyopathy or ischemic cardiomyopathy, because these patients survive longer. In cases of amyloid cardiomyopathy, also it can be done, but usually hypertrophic cardiomyopathy, as it is genetic predominantly, so cardiac transplantation is usually not done. Most of the patients die suddenly. So what you have to do is that you have to take a sample of the left ventricle or maybe right ventricle from the apex and preserve it at -80, cryopreservation, for any mRNA analysis, gene expression, or any genetic study. In addition to that, you take a sample of spleen. So sudden cardiac death, especially for any, why spleen? You might be wondering why spleen. Spleen is rich in lymphoid cells, so it will give you a good amount of DNA. So you can preserve it at -80 and then do whatever genetic analysis later, right? Then of course, on microscopy, you have to look for any inflammation, fibrosis, fat, hypertrophy, atrophy, edema, necrosis, or infarction, right? And when you talk about myocarditis, so the WHO gives a definition of more than 14 lymphoid cells per square millimeter should be present, and they should be predominantly CD3 or could be CD68. If they're predominantly CD68 positive, they are macrophages. That tells you about a resolving myocarditis. If they're predominantly CD3, that tells you about active myocarditis. It may or may not be associated with myocardial necrosis. And of course, we all know when we suspect amyloid, we do thrombotic staining. And this is the transplant heart. So the explant heart and the transplant heart, if there is any problem with the patient later on after the transplantation, so patient can have hyperacute rejection, acute rejection. Later in the course of disease, patient may have graft vascular disease or vasculopathy, infections, which most commonly occurs in our country, drug toxicity, and very late in the course, you may have lymphoproliferative disorders, or there could be disease recurrence in the graft. And sometimes you may have effect of the systemic disease in the transplanted heart. So this is the stepwise plan for the cardiac examination. You all probably see this is being recorded. You can go through the presentation later. So the easiest way from there you can do the dissection of the heart. Now let's come to the case-based discussion, right? Now this was a 47-year-old male, and patient was diagnosed with rheumatic heart disease with severe mitral regurgitation, and in addition there was severe left ventricular systolic dysfunction. Now here I want to highlight is that systolic dysfunction means that there is filling defect of the left side, right? So it's not able to accumulate enough blood in the, it's accumulating the blood, but it's just not able to pump out that blood. Whereas diastolic dysfunction means it's able to just accumulate and it becomes dilated and dilated. So systolic dysfunction occurs in dilated cardiomyopathy and diastolic dysfunction occurs in hypertrophic cardiomyopathy. Now, if you see this heart, the shape is not normal. It's becoming little squarish instead of that conical shape of the apex. And if you see closely, this is something like fibrinous pericarditis is there on the surface. And I was trying to tell you that see the right atrial appendage is absent here. So that means this patient has undergone open heart surgery earlier. And we'll see what open heart surgery this patient had undergone. So there is distortion of the shape, and this heart weighed around 700 grams. The normal heart weight in Indian setting is 250 to 300 in females and 300 to 350 maximum in males. Okay, that's a standard criteria. But this was 700 grams, so it was almost the double of the Indian standard. There is fibrinous pericarditis and there is absence of right wall. Now this is the posterior aspect. So the pericarditis is also seen on the posterior aspect. You see the thickening of the pericardium, so which is adherent to the viscera and the underlying myocardium. Okay. Now this is the opened up right side. If you see the stuck part of the right auricle, this is the right auricle. The tricuspid valve looks normal. So is the right atrium and the ventricle. But what we see here is the right ventricle appears thickened and it measured around 7 millimeters. Now someone asked what should be the exact wall thickness. So for right ventricle, 5 millimeters is the upper limit. For left ventricle, 1.5 centimeters is the upper limit, right? So this is your pulmonary artery and we are measuring the wall thickness just 1 centimeter below the pulmonary valve. So it is around 1.7 millimeters, so it is hypertrophic. And you can again see this bread and butter appearance, which we call it as, which is seen in patients with rheumatic heart disease. Now let's see the left side of the heart. Now this is the left side of the heart, and what you see here a prosthetic valve. And this is severely dilated, thickened endocardium, and the chamber is severely dilated. And this is the disc type of prosthetic valve. So you can see here, so whenever there is closure, so this disc gets closed like this, and when there is opening, the disc gets opened like this. If you see the sutures, probably some of you might be able to delineate. There are blue sutures here. See here, they are normal. There is no hematoma, no ulceration of the endocardium right here. Okay, so it is normal, but there are these nodular areas. So that tells you that there is some foreign body reaction and fibrosis happening around this valve. So this is from the anterior aspect, and this is from the posterior aspect, and you can see these nodules around the valve. Now let's see why the dilatation of the left atria was happening. Why? So there has to be some problem in the aorta also. So that was a prosthetic valve placed in left mitral valve, in the mitral valve on the left side because of the severe mitral stenosis. Now this is the left outflow tract. You see the semilunar valve, 3 cusps are there, but they are fused. They're very, very thick. They're not translucent. Normally the valve cusp and of both sides, the semilunar as well as the valve cusp, they're very translucent and very soft. Here they're appearing markedly thickened. So you see here, this is the left side and this is the right side, and this is the posterior cusp of the aortic valve. And they're very irregular as well, thickened and irregular. And if you examine them on a further closer look, you see a vegetation sitting there. They're very calcified and thickened. So you see here, this is the prosthetic valve from the left side, the mitral valve. So this is your anterior mitral leaflet. So you can see that prosthetic valve from here also, from the aortic side. Okay. Now let's see what it looked like. It showed this extensive hyalinization and areas of calcification. So a lot of fibrosis highlighted on mesones and calcification on the valve. Now this is the section taken from the mitral valve. If you see a lot of neovascularization, very thick walled vessels, fibrosis, and collection of these inflammatory cell infiltrate, which are forming small nodules. And if you see them closely, there are some elongated cells seen. And what are cells? They have this zigzag chromatin. These are nothing but caterpillar cells. So there is formation of active Eschhoff bodies, right? So Eschhoff nodules are there, so Eschhoff cells are seen. And further, panel of pictures to highlight these NS cells having this caterpillar chromatin. This is giving like an owl-like appearance which is described in the textbook. And this is an Eschhoff nodule. Many Eschhoff nodules were seen in the leaflet. And now let's see what happened to the heart itself. So when I did the sectioning from the apex to the base, that is the bread loafing or short axis method, this is what I saw. You had multiple areas of dark and pale cells. And you see this is neural thrombus present in the left ventricle. You see these grey white areas accompanied with these hemorrhagic areas. And they were present randomly. They were not involving one part of the valve, that is the free wall or the septum or the posterior valve. They were involving randomly all parts of the myocardium. So what was it showing? This is the whole mount view. If you see from that area, you have these pink areas, pale areas, and little dark areas. So variability in the appearance of the myocardium. And this is what on the high part looked like. So you had areas of fibrosis. This is what is called as replacement fibrosis. When it is replacing the myocytes, and this fibrosis is accompanied with myocyte hypertrophy with an isonucleosis. So these are the areas which look pale on cross examination. And this is the high part of the other area which showed fibrosis going through the interstitium with an isonucleosis, right? And capillaries are normal in appearance. Okay. Now let's see further closer look of the aortic valve again. Irregular margins, vegetation seen over here, very thickened. You see, this is very, very thickened markedly. And it is also going into the left ventricular cavity. Further, another picture to show the aortic valve stenosis. See the fusion of the valves. See here, it's becoming like a straight line. Normally it should be like this, right? Here it is becoming straight lines, so it's fused. And the sections from this showed extensive hyalinization, sclerosis, calcification, along with fibrin, this granular material and these blue areas. Now, low part may look like that these are calcified areas, but when we looked at them closely, they were all bacterial colonies. Clusters of these bacterial colonies present in the aortic valve where the vegetation was sitting. And when we performed gram stain, this is how the gram stain looked like. Strongly positive for gram stain. So they were all gram positive cocci, causing an infective endocarditis over a stenotic aortic valve disease. And this was causing myonecrosis, forming these thromboemboli within the myocardium. You see, all the capillaries are studded with these bacterial colonies, and because these capillaries are clogged, the surrounding myocardium is showing necrosis. There is spillage of RBCs and there is myonecrosis with neutrophilic infiltrate here. So this is as a result of occlusion of these smaller vessels in the myocardium causing myocardial infarction. And this is a high magnification, one of the capillaries clogged with bacterial colonies surrounding neutrophilic infiltrate, and you see the surrounding myocytes. They have lost their nuclei and they are hypereosinophilic. If you do a longitudinal section, they will look very wavy. This is how it is described as. And even the larger intramural vessels, they showed this presence of septic thrombi. And even in the pericardium, we could see this. So this was myocardial infarction secondary to septic thromboemboli in a setting of rheumatic heart disease involving the mitral valve along with bicuspid aortic valve. Okay. Another picture to show this waviness of fibers, inflammatory infiltrate, septic thrombi, and a high part to show this loss of nuclei in the myocytes, hypereosinophilic fibers. Sometimes you may see contraction band necrosis and bacterial colonies in the capillaries. So this case was a case of chronic rheumatic valvulitis due to aortic valve stenosis, prosthetic valve in the mitral, prosthetic valve which was normal but showing chronicity changes in the valve along with infected endocarditis of the aortic valve. This in turn led on to myocardial ischemia and multifocal infarction of the septum, left ventricle, involving all the valves secondary to septic thrombus. There was biventricular hypertrophy because there was mitral stenosis as well as there was aortic stenosis. So they were causing left ventricular hypertrophy as also along with right ventricular hypertrophy and pulmonary hypertension, which was as a result of back pressure of the blood due to mitral valve stenosis. Right? Any questions about this case?
No questions, Bill.
No question. Okay, now let's move on to the next case. Now this was an explant heart. Now I just told you what is an explant heart. Explant heart is a heart which is removed in a patient where the cardiac transplantation is being done. So this was a 30-year-old male. Clinical diagnosis dilated cardiomyopathy with severe LV dysfunction. You see, heart is flabby. It is maintaining its shape, but it is soft. That's why it's looking flat. This is the anterior aspect and this is the posterior aspect. And this is what I did to this heart. I opened it with 4-chamber method. So you have the right ventricle and left ventricle. This is from the opposite side. So these are mirror images of both sides. And you see the endocardium. It looks very thickened. Very, very thickened. And you have some gray areas in the myocardium as well. So this was a case of dilated cardiomyopathy. And this was very, very recent case. And this is what the microscopy looked like. You had interstitial fibrosis of moderate to severe degree with myocyte hypertrophy accompanied with atrophy with an isonucleosis. This is what you see in a case of dilated cardiomyopathy. Now let me share another case of dilated cardiomyopathy. This was at autopsy. This heart weighed 440 grams. This patient also had associated vomiting and abdominal pain for 7 days and presently had shortness of breath for last 4 days. So this is overweight, definitely 440 grams, and it looks normal. There is no pericarditis, right auricle is nicely seen, but it has neural thrombus present in it. Now when we open it, we see the chambers are dilated. There is some endocardial thickening. This is the right inflow and the right outflow, but no other abnormality. Valves look normal. But when we see the left side, we see a lot of neural thrombi present, a lot of endocardial sclerosis, and there is dilatation of the chamber. You see here again. So this is the left inflow and this is the left outflow. You can identify the aorta here, the aortic valve, the mitral valve here, and the left atrium. So there is presence of neural thrombi along with endocardial sclerosis. And this is what the myocardium showed. It had a lot of inflammation within the myocardium causing myocyte necrosis. You see here, and there were predominantly lymphoid cells, some neutrophils, along with eosinophils. See another picture and high magnification to appreciate the neutrophils and some eosinophils. And we did perform immunostains which were predominantly CD3. Few CD68 positive cells were also seen. So this means that there was an ongoing process of myocarditis. Now whenever you have myocarditis, you have to do the viral genome, virus studies, and we did perform that, and this patient came out to be positive for Coxsackie B virus. And there was involvement of the liver and brain also in the form of hepatitis and meningitis in this patient. And this was published as well from our department. Now let's see the next heart. Now you saw one case of rheumatic heart disease with the aortic and mitral valve involvement. You saw 2 cases of dilated cardiomyopathy. Now let's come to another type of cardiomyopathy. Shape is essentially maintained, but when we can see that there is some increase in the fat on the pericardial aspect, the apex looks blunt. It's not really pointed out. That means usually there is left ventricular hypertrophy. The auricle is fine, but if you see the cross section, that is the apical cut, you have this pale areas which is seen on the posterior aspect. So this is involving the posterior lateral wall of the left ventricle. The free wall is normal and so is the septum, right? Now what does it show? So we again perform the cross LV section, the bread loafing method. So you have these pale areas causing thinning of the myocardium, replacing the myocardium with this scar formation. So this is the case of old heel myocardial infarction, and these are the coronaries. If you see, this coronary is almost showing near total occlusion after nearly 5 millimeters of its origin. And even the left circumflex artery also showing narrowing. However, the right circumflex is relatively spared, no narrowing. When you label a patient as triple vessel coronary artery disease, all the 3 coronary arteries have to be involved, and they should show a narrowing of more than 75%. And this is what the coronary look like. You see almost near total occlusion of the coronary artery. This is your internal elastic lamina, and this is your intima, and lumen is almost closed. And this is what the myocardium showed. So you had multiple areas of replacement fibrosis, some neovascularization and sprinkling of the inflammatory cells, and mesons highlighting the collagen deposition within the myocardium, and the high part showing some histocytic cells in between with vascular proliferation. So that tells you that this myocardial infarction is not very old. So this myocardial infarction is maybe around 4 to 6 weeks old because there are still macrophages present, and neovascularization is still there. The total fibrosis or hyalinization has not taken place. In addition, there was evidence of subendocardial ischemia with this myocardial vacuolar changes in the myocytes. So this was a case of dilated cardiomyopathy, secondary to ischemic heart disease. So also called as ischemic cardiomyopathy, right? Let's come to the other half. This was a case of 32-year-old female. This patient also had clinically diagnosed with dilated cardiomyopathy. The patient suffered from VT and had a history of old cardiovascular accident. Now you must be wondering, 32-year-old female, what's the problem with her? Why she's having ischemic strokes at 32? Is she hyperlipidemic? Is she having coronary artery disease? That's the first thing you think of. The heart rate is essentially normal, 270 grams. The shape is normal. There is some dilatation of the right auricle, but no thrombus. When you open up the left side, this is what you see. There is thickening of the endocardium, and which is adherent to the underlying myocardium, and some whitish areas are also seen going into the underlying myocardium, right? And the wall thickness is around 1.5 centimeters. So it's not really thickening of the wall, but there is thickening of the endocardium happening. Okay. And this is a closer look. You see here, the myocardium looks like an ivory paint-like appearance, as if someone has poured some paint into the cavity. And this is how it looks. Normally, the endocardium should look like translucent. Here, the endocardium is patched onto the myocardium, and there are these venous streaks of fibrosis running into the underlying myocardium, involving even the papillary muscle. Okay. And this is to compare. This is the case of dilated cardiomyopathy. You see here, this is also endocardial sclerosis. This is also endocardial sclerosis, but this is patchy. This is diffuse. So that's what the difference is. And here, the underlying myocardium is not showing this venous streaks, whereas you can see it over here and involving the papillary muscle also. Now, another closer look to appreciate this venous streaks of fibrosis, thickened opaque endocardium with involvement of papillary muscle. And this is from the apical slice. So you see very thickened endocardium. And this is the whole mount. You see thickened endocardium, pink areas and some pale areas. Okay, now let's see the high magnification. So marked thickening of the endocardium due to fibrosis, and this fibrosis is extending into the underlying myocardium. See, these are the myocytes, and this is highlighted by this mesons. You see thickening, fibrosis. But comparatively, if you see these myocytes, the fibrosis is limiting itself here. After that, there is no significant fibrosis. Now, what would be the cause? Another panel of picture to appreciate this endocardial fibrosis going into the underlying myocardium. Next slide, and the mesons highlighting the same. Now, this is to compare. This is thickened endocardium. So you have this deposition of elastic fibers in a lamellated fashion. This is a case of endocardial fibroelastosis, where you have deposition of elastic fibers in the endocardium, again causing thickening of the endocardium. And this is the HME of the same, and this is the Orsi and mesons. There is no fibrosis. Mind it, there is not deep blue color. Comparative to our case presently, where you have endocardial fibrosis, which is dipping down into the underlying myocardium. And this is a section from papillary muscle, which also shows this fibrosis. So this is a case of endomyocardial fibrosis, which is usually seen in the down south part of our country with consumption of tapioca, right? And this is the left inflow, which also showed thickening of the endocardium, and the right outflow, which is essentially normal, but it had endocardium. So basically, both side ventricles were involved because of the endocardial thickening. And these are the section from the right ventricle. Again, you see thickening, not much of elastic tissue here, and it is going into the underlying wall, but limiting itself to the half of the myocardium. The later half is normal. And coronaries were normal. Now, before you say that this is endomyocardial fibrosis, you have to rule out whether there is any myocardial coronary artery occlusion or not. So they were normal, but the intramyocardial vessels did show narrowing, right, with reduplication of plastic lamina, causing these interstitial fibrosis. Of course, this was during COVID time, so we did perform all the viruses in the heart, and we also did COVID tests. Everything came out to be negative. However, the enterovirus came out to be positive, which I was not expecting. So maybe it's a bystander. Patient might have had suffered from myocarditis earlier in his life. We do not know that history. So we have a normal weight heart, narrow ventricles with biventricular hypertrophy in this case, marked endocardial fibrosis involving 1/3 of the myocardium, valvular thickening, and intramural vascular changes. So while it is not dilated cardiomyopathy, because you have endocardial fibrosis and myocardial fibrosis, but the physiology is of restricted type, but the phenotype is dilated type. So why not? Because there are no mural thrombi, no chamber dilatation, normal coronaries, of course, myocardial thinning is absent, and valvular regurgitation is not there, and the presentation is of systemic dilated type only. Okay, so the final line in this case was endomyocardial fibrosis, the secondary effect on the heart and lungs. Okay, let's come to the next case. Any questions for these two cases?
No, madam, no questions.
Now this was a case of again an adult male. The shape is maintained, but the auricles look little discolored from outside. So you can see some hemorrhagic discoloration. So this was containing a thrombus, and it is overweight. It's weighing 370 grams. And if you open it up, you see that this is the right inflow, looks essentially normal. The left inflow also looks essentially normal, but the muscle appears to be thickened. And on this side also, the muscle appears to be thickened. This is the left outflow. And it's very difficult to open up the heart. And there are some neural thrombi present here. And this is what the heart. So another thing which I want to highlight here is the cuts are very clean and sharp. Normally, this is not the type of cut you see. So they were appearing little dark brown in color, and the cuts are very sharp. And when you saw the microscopy, this is what the heart showed. Had this eosinophilic material deposition in the subendocardial location and around each myocyte, causing myofibular degeneration. And this is another picture in the subendocardial location, and a PS H2 stain which shows very weak or negative PS positive, negative PS in the amyloid, and apple green birefringence on the congruent stain. A hyper of the underlying myocardium, so this presence of amyloid into the myocardium involving almost each myocyte. Nothing was spared. So vessels also showed deposition around them, and apple green birefringence, and SAA was negative. And this is again one of the subendocardial area. Fortunately, we also had a biopsy in this patient. So this was the biopsy prior to the demise of the patient, which again shows this interstitial deposition of the amyloid, which was congophilic. And EM showed this. Now this is to compare. This is the collagen. You have parallel stack of bundles. This is how collagen looks like, but the amyloid fibrils are very fine and crisscross. So it was confirmed on electron microscopy, and it was AL type of amyloid. Right? Now let's come to the next case. That was a 49-year-old male. And clinically, the patient was diagnosed as hypertrophic cardiomyopathy. And this is what the heart looked like. If you see, there is dilatation of the left side. There is hypertrophy of the bowel. Both the septum as well as the free wall are hypertrophy. It's almost 2 centimeters. And this is the cross LV. Now, what you see on the cross LV is that the free wall and the septal wall, they're almost measuring same. And there are some whitish gray white streaks are seen within the myocardium. That is again representing fibrosis. And this heart is 540 grams. Now, remember here, the heart rate is usually increased either due to muscle mass, some infiltration, effusion, or there is a tumor present. So, lymphomas and any other malignant infiltration to the heart also because increase in the heart rate. And this is the 4-chamber method which I tried. I shared this picture earlier also. So, you had a septal thickness which measured around 15 millimeters. So, significant enough to call it as a hypertrophic cardiomyopathy. And see here, now difference between the previous one and this one is that septum and the free wall. This is the free wall, this is the septum, they're almost same. So this is not a case of hypertrophic cardiomyopathy. The chamber is still maintaining its shape. In HCM, if you see, the chamber becomes almost obliterated. Okay. And this is the microscopic look like. Now you must have noted myofiber disarray. This is the exact picture of myofiber disarray. So they're crisscrossing each other. And you have this interstitial fibrosis. Unlike the case of dilated cardiomyopathy, where there is replacement fibrosis. Okay. And this is how the hyper look like. See myofiber disarray, so it's like looking like a heavy bone pattern, right? And a meson stain highlighting each myocyte surrounded by the fibrosis. Here also, so this is called as myofiber disarray. In late stages of hypertrophic cardiomyopathy, when the entire myocardium is replaced by the fibrosis, it may have a dilatation ultimately. Now, the point why I'm showing this picture is that in hypertrophic cardiomyopathy, there's a disarray of intercalated disc and myofibrils. So you see, this is your intercalated disc. This is your A band, and this is your Z disc and M band. So this is the normal myocardial electron microscopy picture. What happened in this patient? The bands are normally in place. Mitochondria are enlarged, but the intercalated discs are disrupted. See here? So there is myofibrillar disorganization with disruption of intercalated discs. That's why there is disarray of the myofibers, or you can say crisscross fibers, because the heart is contracting in its own manner. Fibers are अपनी मर्जी के मालिक हैं, जहाँ मर्जी जाएंगे, because there's nobody to control them, right? That's what happens when there is no control. And the intramural vessels in hypertrophic cardiomyopathy, you should look for them. And that's a clue that you're dealing with a case of hypertrophic cardiomyopathy, which shows thickening and aneurysmal outpouchings with fibrointimal hyperplasia, right? It's a clue, especially if you get a biopsy of hypertrophic cardiomyopathy, endomyocardial biopsy. If you get to see intramural vessels, look at these changes. Okay. And of course, the coronaries were dissected; they were normal in morphology. And these are some of the areas which were looking like grey white, which showed some degree of replacement fibrosis, secondary to the long-standing hypertrophic cardiomyopathy. Now, this patient, an interesting case. This was a 42-year-old male. Usually, hypertrophic cardiomyopathy does not survive this long. But this patient behaved like dilated cardiomyopathy later in the disease because he did not have any common mutations. However, there were some genes which were identified which are not very common. So this patient phenotypically was behaving like dilated cardiomyopathy. He survived for 20 long years after diagnosis. He died of heart failure, unlike HCM, which usually dies suddenly, right? Whereas heart failure usually is a feature of ischemic type of cardiomyopathy or dilated type of cardiomyopathy. Okay, so this was the final diagnosis in this case. So now that's the end of my talk. I do not know with this picture how many of you are feeling like this. Was it such easy thing or was it very difficult? But I think I could bring a smile showing this picture to all of us. Thank you so much for your patience, and I'm open to any questions. And this is our famous rock garden from Mr. Nature. Thank you. Any questions? I'm happy to answer.
No questions.
Yeah, please. I'm happy to answer those.
Currently, there's no question in the chat.
Anybody wants to ask anything else? Anybody? So I first want to ask all of you, how much have you understood? I've showed you a variety of examples of different types of cardiomyopathy, rheumatic heart disease, endomyocardial fibroblastosis, and a case of even endocardial fibroblastosis, right? So did you understand the difference between the two entities? Did you understand the differences between type of cardiomyopathies, BCM, HCM, RCM? So how will the myocardium look like in BCM versus HCM versus RCM? Anybody? I think they're all flabbergasted, I guess so.
All of them are basing your
This is the lecture, madam. This is really good, very informative lecture.
Thank you so much. Thank you. I tried to make it simplified so that they can understand. I didn't want to go into the theory because cardiac pathology is mostly gross examination. Microscopy comes later, but you have to know after gross examination what you're dealing with. So if you look at the soft heart, it's mostly dilated cardiomyopathy. If you look at the firm heart, rule out a hypertrophic cardiomyopathy vis-a-vis dilated cardiomyopathy. If you're looking at the very large areas of pale grey white areas, thinning out of ventricle wall, rule out an ischemic type of dilated cardiomyopathy. Mind you, ischemic cardiomyopathy also causes dilated cardiomyopathy. And of course, I've not discussed about the alcoholic or cirrhotic cardiomyopathy, which is common around 13% of patients of cirrhosis. HCV and HBV. HBV relatively less can have cardiomyopathy features. So these patients need to be kept on follow-up. And there are many other types of cardiomyopathy and heart diseases which I have not shown. This was only meant to show you the spectrum of major diseases which we encounter in day-to-day practice. And RHD, of course, was I think, icing on the cake. I guess so.
Yes, ma'am.
It was a 700-gram heart, and we were all like, how could it become so big? In spite that patient had undergone surgery, mitral valve replacement by the prosthetic valve. So, but still the patient died. So, anybody wants to add something? Kani, are you there?
Yes, I'm here. Thank you so much.
You're most welcome.
It was a rather a revision to me, quick revision, and we are all fortunate, including the viewers, are very fortunate to have the whole subject in a nutshell. You have put it in just in 1 hour. So
yeah, because I didn't want to exceed up to 1 hour because I know the concentration goes down, so I don't want to do that. So I restricted it that I have to be .8. I should finish.
I have one doubt. As a resident, I had this doubt actually. So hopefully the others also would be having this.
Yeah.
How to differentiate between myocarditis and infarction? Both will have inflammation.
Okay, so very good question, Kanyapan. But usually myocardial infarction will have neutrophils. Most of the time we do not get autopsies of myocardial infarction, but because the diagnosis is made antemortem. One, if you remember, I showed you a case of RHD which had myocardial infarction,
Yes,
but that was secondary to the septic thromboemboli. Now in myocarditis, you will have multiple foci of involvement. Whereas in myocardial infarction, you will have territorial distribution. By that I mean one artery will be involved or two arteries will be involved. So if you have involvement of left anterior descending, it will be your left anterolateral wall of the left ventricle will be involved by myocardial infarction. If right coronary is involved, it will be mostly the posterior valve and the lateral posterior inferior wall which will be involved. So territorial distribution is an important factor. Plus multifocal nature of the infiltrate. And in myocarditis, it is usually lymphocytic unless and until we are talking of hypersensitive or loftless myocarditis. Whereas in myocardial infarction, it will be neutrophils. And when it comes to the healing stage after 72 hours, when macrophages starts coming in, the case I showed was I think 4 weeks of myocardial infarction. So macrophages started coming in and vascular proliferation and fibroblastic proliferation starts taking place, which doesn't happen in myocarditis. Okay.
Thank you so much.
Any other person?
No questions, ma'am.
Okay. Good to go. Either all clear or none clear.